Good morning, sir.
Good morning. Yes.
Sir, a 76-year-old female admitted yesterday with complaints of headache since 15 days, newly onset, throbbing in nature, with band-like involving the forehead and occiput, which is aggravated by the evening hours, 1 to 2 hours. No history of fever.
It lasts for 1 to 2 hours.
Yes, sir.
76-year-old female. Is it a new onset, first time headache?
Yes, sir. It's a new onset first
Since
time.
how long?
So since 15 days.
Okay. Please again describe the character. What was it? Throbbing.
So it was throbbing in nature with band-like involving the forehead and occiput.
Okay. Band-like involving forehead and occiput.
Yes.
Okay. Okay.
Patient doesn't have any.
Till what time it lasts? Once it starts?
So it starts in the evening and it lasts for 1 to 2 hours.
Usually occurring in the evening, 1 to 2 hours it lasts.
Yes, sir.
Okay. Then go ahead.
So patient doesn't have history of fever. Patient doesn't have any disoriented nature, seizure or weakness, or no any focal neurological deficit. Patient doesn't have diplopia, blurring of vision, or doesn't have a history of vomiting.
So this is the negative history part.
Yes.
Okay. In the past history, is there any significant past history you want to comment?
So patient newly detected with hypertension since 1 month.
Okay. Newly detected hypertension since 1 month.
Patient has been prescribed medication, but she is non-compliant. She is not taking any medication. Sudden brief examination. So the pulse,
Examination, any positive finding in general examination?
so the pulse is normal. All peripheral pulse are present, but the BP on the right arm is 180 by 100 and the left arm is 170 by 108 mm of Hg.
Okay, she is hypertensive and she was not taking medications.
Yes.
And currently blood pressure is 180 by 110.
Yes.
Okay.
All other systemic and neurological examination is normal.
Okay. So you have examined neurology, normal, she is alert, heart functions are normal, no focal deficits, cranial nerve examinations are normal, motor sees everything is fine. Sensory exam there is no complaint. Okay. So we are dealing here with a case of a headache in an elderly female. In an elderly female, more than 50 years of age, new onset headache. The way you have described the headache is, it looks like a tension headache. It looks like a primary headache. Or maybe it is due to, this tension headache can be due to hypertension. Hypertensive headache, hypertension may present as headache, and the classical headache of hypertension is actually, it is a headache throbbing type or dull aching type which occurs in the occiput, sometimes in the mid portion of the skull or the head and occipital area, along with some fatigueness and pain in the neck, posterior neck and neck area, usually in the evening hours, and may be associated with vertiginous symptoms. And it is the usual probable presentation of a hypertensive headache which is undetected and undetected blood pressure, and the patient comes out to be hypertensive. But remember, and you said that it is a band-like sensation in the frontal part also in the occiput. This usually a classical description of the tension type headache, idiopathic tension type headache. But whatever, remember always, even if she is hypertensive, this lady should be neuroimaged. Another thing, most important thing, any new onset headache after the age of 50 years, we should always consider giant cell arthritis. Okay. This entity should be considered, should be talked out with the patient as far as the clinical presentation is concerned, and should be ruled out. And if any suspicion, should be investigated also. So let us first discuss about giant cell arthritis. Usually the headache you described is actually not a classical presentation of giant cell arthritis. Usually the elderly female first time headache, they will present with unilateral headache, especially in the temporal area. And they will say that it is a very throbbing character of headache, pulsatile throbbing headache. And when you examine, there will be dilated tortuous temporal artery. There will be dilated and tortuous temporal artery. Here there is no visible dilated tortuous temporal artery. Okay. So when you palpate that temporal artery, that will be tender. Rather, this whole area will be tender. If you ask a leading question, she may say that yes, when I am combing my hair, I am having irritation and painful sensation in this area. So there will be localized scalp tenderness also. When you ask certain questions like, do you have pain during chewing for a prolonged period of time? She will say there will be pain in chewing, which is known as jaw claudications, and sometimes in 15% of cases, they will be also coming out with the positive history of, which is known as polymyalgia rheumatica. That is stiffness in the shoulder joints, stiffness in the proximal joints, difficulty in getting up from squatting position. This is one association in 10-15% of cases of Janssen arthritis. That should be always ruled out. Even if we are not considering it, but still we will do an ESR. If ESR is more than 40, we have to be cautious little bit what we are dealing with. And if ESR is normal, we will rule it out. Secondly, these for any new headache, even elderly should be neuroimaged. Did you do a neuroimaging?
Yes, sir. I have read the neurology.
Let us chat on the neuroimaging.
Yes.
So yes, we are having findings here. So this is an MR angio. What you are showing me here is, we can see the internal carotid artery. This is the middle cerebral artery, and this is the anterior cerebral artery. So you can see here, this is the pathology. Maybe this is an aneurysm. The internal carotid and middle cerebral, this is an aneurysm. This is the bad thing here. I cannot say that this is itself causing the headache, but what we have detected is bad. Okay? So let's discuss on this thing. So can you tell me, what are the complications of an aneurysm, intracerebral aneurysm and detected? So yes, what hemorrhage?
So subarachnoid hemorrhage.
Very good. The first thing you will talk about is subarachnoid hemorrhage. Can you tell any other cause of subarachnoid hemorrhage? Apart from ruptured aneurysm, other causes can be rupture of an AV fistula, arteriovenous fistula, that can cause subarachnoid hemorrhage. Even trauma can cause subarachnoid. And excessive anticoagulant therapy, low platelet count, okay, bleeding diathesis, drugs side effects like thrombolytics causing intracranial hemorrhages, they might present as subarachnoid hemorrhages. Okay. When we talk of hemorrhage, one we have segregated as aneurysmal rupture, these are Berry's aneurysm. Aneurysmal rupture will cause subarachnoid hemorrhage. Another, when we talk of hemorrhage, is intracerebral bleed. Subarachnoid means we are talking of bleeding inside, just underneath the subarachnoid space. Subarachnoid space, the layers of the movement. When we talk of intracerebral hemorrhage or intracerebral bleed, remember hypertension is one of the most common culprits. So which is known as hypertensive intracerebral bleed. Okay, come on. So hypertensive intracerebral bleed, there are aneurysms which are known as, not Berry's, small microaneurysms which are known as Charcot-Bouchard's aneurysm in hypertensive patients. And when uncontrolled hypertension leads to a hemorrhage, there are mathematically 4 to 5 areas. 4 areas where there will be intracerebral bleed. If these areas are bleeding, or you see the neuroimaging that are bleeding in these areas, it is likely mostly due to hypertension. The first is putamen, the globus pallidus, putamen. Then second is thalamus. Then third is the pons, and fourth is cerebral. These are the 4 areas where if there is intracerebral bleed, hypertension is the problem. And another type of bleeding that can occur in neurology is a lobar hemorrhage. Hemorrhages in the lobes, the frontal lobe, parietal lobe. And lobar hemorrhage usually occurs in an elderly. The first possibility, the pathology we talk of is amyloid angiopathy. There are amyloid deposits in the blood vessels, and whenever there is a lobar hemorrhage, the etiology is usually amyloid angiopathy. Okay, out of these hemorrhages, the treatment of choice in subarachnoid hemorrhage is you have to coil or clipping or coiling. Nowadays they are coiling the aneurysm. So if we discuss about this aneurysm, it looks large. What is the size? Can you tell me the size?
So 9 into 7 millimeters.
So it's a large aneurysm. It requires coiling. This patient should undergo coiling. Now coming down to whether this was the culprit of her headache. So classically, aneurysmal rupture will present as a thunderclap headache. And there will be disorientation. Patient can present in drowsy state, coma with a thunderclap. But this lady is alert. Maybe this is an incidental finding, but should be targeted because there is an application. I think it is the hypertension which is causing, and still, metaphysically speaking, that hypertension can create a bad impact on this aneurysm also. So hypertension should be controlled, and we should consult intervention neurology for the tackling of this, spoiling of this aneurysm. So, to summarize, intracerebral hemorrhages can be due to rupture of aneurysm, subarachnoid hemorrhage. Then you should know about the intracerebral bleeds, the areas, and thirdly, about lobar hemorrhages, amyloid angiopathy. Other causes of hemorrhage may be tumor bleeds. Vascular tumors like glioblastoma multiforme can bleed by themselves, right? And another thing is when there is a large infarct and you are thrombolizing the patient, there can be hemorrhage inside the infarct. Large. If you remember the contraindication of thrombolysis in stroke, if there is more than the middle cerebral periphery is involved, there is a large infarct in the middle cerebral periphery. Usually it is aortic. Okay. So these are the important things that can be asked in headache. And remember, lastly, to conclude, giant cell arthritis should be entertained in any patient, elderly patient presenting a first time headache after age 50.